Hello everyone, I am Beatrice. In today's video, we will look at diabetes insipidus. Diabetes insipidus is the opposite of SIADH, that's syndrome of inappropriate antidiuretic hormone. I've done a video on that, so be sure to check it out. And this is part of endocrine review. Now, for this diabetes insipidus, we'll be looking at the causes, the signs and symptoms, and diagnosis, and how to manage this condition. I'll be giving you some tips, especially for your NCLEX, because this topic, together with SIADH, is commonly tested in NCLEX. And also, before the end of this video, I have some NCLEX-style questions that will test your knowledge on this topic. So if you are ready for today's video, let's begin. Diabetes insipidus is a condition where the body produces less antidiuretic hormone. Now, this antidiuretic hormone is synthesized or produced by the hypothalamus and stored in the pituitary gland, particularly in the posterior pituitary gland. Now, when there is need for this antidiuretic hormone, it is released in situations where, let's say, there is low blood pressure, low blood volume, or there is high osmolality of the blood, or there is dehydration. It is released so that it can help the kidney reabsorb fluid back to fix that dehydration, to dilute that excessive concentration of the blood, to fix that low blood pressure, because when there's increase in blood volume, the blood pressure will also come up. But in a situation where there's less antidiuretic hormone, what will happen is that the patient is going to keep losing fluid because the kidney will not be able to reabsorb fluid back. So as the patient takes in any fluid, the patient loses a lot of this fluid in the urine. Now take note, diabetes insipidus is not a form or type of diabetes mellitus. In fact, it's a different thing entirely. Diabetes mellitus has to do with problem with glucose metabolism. I've done a video on that, so you can check it out. But it shares that same first name, which is diabetes, with diabetes mellitus because of the fluid part, where the patient loses a lot of fluid. And will now manifest all those symptoms that are also unique to diabetes mellitus, the fluid part. So things like dehydration, polydipsia, polyuria, nocturia. So don't confuse it, they are not the same at all. Now, there are two forms of diabetes insipidus. It is either it is neurogenic diabetes insipidus, or we call it central diabetes insipidus, or it's nephrogenic diabetes insipidus. Let's break it down. For neurogenic diabetes insipidus, it means the problem has to do with the brain, either with the hypothalamus not producing this antidiuretic hormone, or it's even with the pituitary gland not releasing it when it is needed. Or it could be due to nephrogenic. So when you say nephrogenic, it means the problem is with the kidney itself. So the kidney is not doing the work of reabsorption, even when the signal is sent. Now let's look at the causes. What can cause diabetes insipidus? One of them is brain tumor, and then we have neurosurgery, like hypophyseectomy, where they cut the pituitary gland, maybe to treat conditions like Cushing's syndrome or some tumors, and then head trauma. And then we have infection and even inflammation. So like in the brain where there is infection or inflammation, like in meningitis, in encephalitis, or infection to the kidney, it can cause diabetes insipidus. Then we also have medications, especially those medications that are toxic to the kidney, what we call nephrotoxic medication. Any medication that is excreted, particularly by the kidney, some can be toxic to the kidney and it can cause this problem. And another thing, it could be autoimmune. Now let's look at the signs and symptoms of diabetes insipidus. So one of them is polyuria. That means they will be losing excessive urine. Then there's polydipsia. Of course, as you are losing fluids, you are going to feel thirsty. Then nocturia, this patient may wake up at night to urinate. Then we have hypotension. So of course, with less fluid volume, or when you are losing lots of fluid, it's going to affect the blood volume, which invariably will affect the blood pressure. Dehydration, which is linked to that loss of fluids. And then weight loss, fatigue, poor skin sugar, that's a sign of dehydration. Then we have constipation. Normally, the colon itself is supplied with about 1.5 liters of fluid. But out of this 1.5 liters of fluid, only about just a small percent, like 10%, is actually used by the colon. The rest, about 90%, is reabsorbed back. But when a patient is dehydrated, it's going to worsen that reabsorption because the body will sense that they don't have enough fluid. It will hold more fluid back, making the stool very hard and dry. Now we have dizziness. That's another one that can happen in a patient that is losing fluid, is dehydrated. Now let's look at the diagnosis or lab findings. Now, first, the urine. What will happen? The urine, if a patient is losing so much fluid, there's going to be low specific gravity of the urine because the urine will be so dilute. The normal specific gravity of urine is 1.005 to 1.030. But for a patient that has diabetes insipidus, it's going to be less than 1.005. The next one is low urine osmolality. That means the urine is also going to be very dilute. It will be less than 200 milliosmol per kilogram. And then there will be decreased urine sodium. Of course, when the urine is so dilute, there will be less sodium in the urine. Now, on the flip side, let's look at the blood. Of course, it's going to be the opposite of what will happen for the urine. So for the blood is going to be so concentrated. That is increased serum osmolality. And also there will be increased serum sodium. So what it means is that if the sodium that is lost in urine is low, is small, so what will happen is that there will be more sodium in the blood. That's hypernatremia. Now let's look at diagnosis. They could do 2 tests to diagnose this condition. One of them is water deprivation test. So as the name goes, water deprivation. So you deprive the patient of water for a period of 8 to 16 hours. Now, the essence is to test the ability of the kidney to concentrate urine, because usually if everything is working fine and you are dehydrated, what will happen is that the kidney should be able to hold back fluid because it doesn't want you to lose more fluid because you're already dehydrated inside. So that's the essence of this test. Now take note, when a patient is undergoing this water deprivation test, you need to monitor the patient closely. If you notice the patient is feeling too dizzy or is feeling restless, you have to stop the test. The next one is desmopressin test. So desmopressin is a synthetic form of antidiuretic hormone. So for this test, a patient will be given the ADH to test if the kidney is able to reabsorb fluid back. So if a patient is given this synthetic form of antidiuretic hormone called desmopressin and the kidney is able to reabsorb fluid back, it means the problem is not with the kidney. That means the kidney is doing the job. It's just that it's not getting signal, or the pituitary gland is not releasing or secreting that antidiuretic hormone to work on the kidney. But in a situation whereby even after this patient has received this desmopressin, yet the patient could not still reabsorb fluid back or is just still losing a lot of fluid, it means this time around is not central. It has nothing to do with hypothalamus or the pituitary gland. It means the problem is within the kidney itself. So that means we'll say in that case it is nephrogenic. In other words, this desmopressin test can be used to differentiate if the patient is having central diabetes insipidus, or what we call neurogenic diabetes insipidus, or if it is nephrogenic diabetes insipidus. Now let's look at management nursing intervention. Of course, with the pathophysiology of diabetes insipidus, you will know that the nursing diagnosis will be centered around fluid volume deficit. So your intervention will be around fixing that excessive loss of fluids. Now, the first one is hormonal replacement of antidiuretic hormone. So if the patient doesn't have antidiuretic hormone or doesn't have enough of it, they can give the synthetic form of it, that's the desmopressin. The next one is low salt diet. Remember, with diabetes insipidus, the patient have increased serum sodium, so there's hypernatremia. So the patient will be encouraged not to take a lot of salt because they already have a lot of salt in there. Then we have thiazide diuretics. Now, for the purpose of thiazide diuretics in this case, it's not to help you lose fluid or remove fluid from the body. It's also, thiazide has the ability to help the kidney reduce urine loss. So it's given to reduce urine volume. And then we need to monitor intake and output. For a patient that is losing so much fluid, you need to monitor intake, monitor output. Also, you can also monitor electrolyte. Then we have good hydration. Of course, a patient that is losing so much fluid, you need to keep them hydrated. So a lot of fluids is needed for a patient with diabetes insipidus. So in a way of summary, for diabetes insipidus, it has to do with problem with antidiuretic hormone production. There's low production or there's no production of antidiuretic hormone, or there's a problem where the antidiuretic hormone is not doing the work effectively, making the patient to lose a lot of fluid. So your nursing diagnosis is centered around fluid volume deficit. So you are fixing those problems that has to do with fluid loss. So now let's review some NCLEX-Style questions that will test your knowledge on diabetes insipidus. Question 1. A client is admitted with diabetes insipidus. Which laboratory finding would the nurse expect? A. Serum sodium 118 milliequivalent per liter. Urine specific gravity 1.030. B. Serum sodium 150 milliequivalent per liter. Urine specific gravity 1.002. C. Serum sodium 140 milliequivalent per liter. Urine specific gravity 1.010. And D. Serum sodium 135 milliequivalent per liter. urine specific gravity 1.020. The answer will be B. Serum sodium of 150 milliequivalent per liter, urine specific gravity of 1.002. The reason is because in diabetes insipidus, there is a lot of water loss, and that will cause hypernatremia, high sodium in the blood, and there will be very dilute urine, so with low specific gravity that will be less than 1.005. Question 2. A nurse is caring for a client with central diabetes insipidus. Which medication would the nurse anticipate administering? A. Desmopressin, B. Furosemide, C. Dimethyl, that's diclomycin, and D. Hypertonic saline, 3% sodium chloride. The correct answer will be A, which is desmopressin. Now, central diabetes insipidus is also called neurogenic diabetes insipidus, so it's caused by lack of antidiuretic hormone secretion by the pituitary gland. Desmopressin is a synthetic form of antidiuretic hormone, so it's there to act the way antidiuretic hormone will act to help reabsorb fluid back. Other drugs that are listed there are for SIDH, not for diabetes insipidus. Question 3. Which clinical finding is most consistent with diabetes insipidus? A. Polyuria and polydipsia, B. Weight gain and edema, C. Low serum sodium and confusion, D. Oliguria and hypertension. Now the correct answer will be A. Polyuria, polydipsia. You remember the hallmark sign of diabetes. So polyuria has to do with excessive dilute urine, and then polydipsia, of course, when you are losing a lot of fluids, you're going to feel excessively thirsty. Question 4. A client with diabetes insipidus is at greatest risk for which complication if untreated? A. Cerebral edema, B. Severe dehydration and hypovolemic shock, C. Syndrome of inappropriate antidiuretic hormone secretion, D. Hypokalemia due to excess potassium loss. The correct answer is B. Severe dehydration and hypovolemic shock. We know that diabetes insipidus causes you to lose a lot of fluids, so that can lead to severe dehydration, can cause hypotension, and eventually shock. Question 5, that's the last question. The nurse is reviewing discharge teaching with a client newly diagnosed with diabetes insipidus. Which statement indicates a need for further teaching? A. I will weigh myself daily to monitor fluid balance. B. I should drink water whenever I feel thirsty. C. I will take my desmopressin exactly as prescribed. D. I should avoid drinking fluids because I'm already urinating a lot. The best answer will be D. I should avoid drinking fluids because I'm already urinating a lot. This shows that the patient does not understand. For diabetes insipidus, they are urinating a lot, they are losing a lot of fluids, so they shouldn't stop or avoid drinking fluids. Instead, we encourage them to drink a lot of fluid to avoid dehydration and risk of shock. So that wraps us today's topic on diabetes insipidus. If you find this video helpful, please like, share, leave your comment, and subscribe for more educational videos. Thanks for watching.